Hello, good afternoon, everyone. Welcome to the second webinar from our series, Rheumatology Revealed 2.0, Advanced Insights and Evolving Best Practices for Family Physicians, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Dr. Aniola Salami, and I am a family physician and assistant professor in the Department of Family Medicine and a medical director at the Physician Learning Program. The Office of Lifelong Learning is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. I'd like to take some time to do the land acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehio, Niitsitapi, Black, Métis, Nakota, Dene, Haudenosaunee, Anishinaabe, and Ojibwe Saulteaux lands that are now known as part of Treaties 6, 7, and 8 and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I wanted to start off this webinar with some housekeeping information. Please use the chat feature if you have a question about technical difficulties or a question about L3 programs and services. If you have a question for our speaker, please use the Q&A feature of the webinar so that your questions can be recorded. Those questions will be collated in that section. And if you see a question that has already been there that you have, just upvote that question. So please review what's already been asked and upvote the questions that you would like to be answered. Because there's likely to be a lot of questions, we can't guarantee that we'll answer all of the questions that are submitted, but we'll try and answer as many as we can. A recording of the webinar will be sent via email to all those who registered, generally about a week after the assessment, or the webinar, I should say. And participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. For more information, you can scan the QR code that's on the slide here, and it'll give you more information. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. For Main Pro Plus participants, you can also earn additional certified credits by completing a linking learning exercise. I now want to take some time to introduce our distinguished speaker. So today we're very pleased to welcome Dr. Stephanie Keeling. Dr. Keeling will be presenting on how to navigate lupus. She will provide the latest in diagnosis, management, and some information on when it will be useful for us to refer. Dr. Stephanie Keeling is a professor of medicine at the University of Alberta in the Division of Rheumatology. She completed her master's in experimental medicine with Walter Maskimowicz, studying inflammatory back pain and spondyloarthritis. She has established the Lupus Clinical of Northern Alberta, LUNA, as well as the On Track, On Treating Rheumatoid Arthritis Access to Care program with co-director Stephen Cates. She was the principal investigator of grade-based recommendations for the diagnosis and management of lupus in Canada and is now leading new treatment guidelines for lupus in Canada. She continues to investigate peripartum outcomes in Albertans with connective tissue disease and inflammatory arthritis at a population level. She also participates in the teaching of medical students, residents, and fellows. I was one of those people. Not to make her feel like she's older, but I was one of those people who benefited. So thank you so much for being here, Dr. Keeling, and thank you so much to everyone for being at this webinar.
I remember well, and thanks for the introduction, and I'll share my screen with everybody, and we'll get going. And let me just move my little legend at the top. So thank you so much for that super kind introduction. I am really delighted to talk about lupus. It's sort of it's like my baby, but it's a disease that has always compelled me since I was a rheumatology resident. So the goal in the next 45 minutes or so would be to try to just shed some more light on how we're diagnosing lupus with the clinical features and the investigations, and recognize there's a lot of heterogeneity in how we diagnose it and how it links with the antibodies that we measure. Try to give some insight into how and what should be referred and how to assess urgency for those referrals, although that is tricky, I acknowledge. And then a bit of the treatment approaches, because there's a whole new explosion of lupus treatments that are just on the cusp of coming out. So these are my disclosures. And I think I want to start by saying that like, as a rheumatology resident, I didn't appreciate the variety of ways lupus has affected all these patients that I had the privilege of seeing. So there's a lot of stories that our lupus patients tell. And I want to start by just kind of briefly showing you some of the exposures that I had. Like when I was a rheumatology fellow at University of British Columbia, and I remember driving to work one morning and we got a call from the ICU about an 18-year-old boy who had presented with pulmonary hemorrhage and acute renal failure. And in that question, they said to me, does rheumatology want to see him for suggestions before they actually consider withdrawing care? I mean, to me, that was a very shocking exposure to this disease, and tells you the life and deathness of this, or mortality potential of lupus. In contrast, lupus can also be very devastating from what the damage it causes. So this is actually, with consent, one of my patients, but I actually met her when I was a resident in Dr. Alex Yann's clinic. He's a retired rheumatologist from Edmonton. She had horrific discoid lupus, as you can see, with a lot of disfigurement and scarring. And she tried many therapies at the time over the past 2 decades, but she lived a really sad, complex life because of how disfiguring it was, and would say, her daughter's friends would ask why she was looking like a witch when it wasn't Halloween. So I tried to imagine, what her life must have been like, and still is. Um, Again, the varied presentations, I think, was impressed on me as well when, for example, I had a young Asian male patient who had bad lupus arthritis. And so like this X-ray here you see shows like a phenomenon that we see in lupus, where patients develop what's called Jacquard's arthropathy. So they don't get the erosions like a rheumatoid arthritis or a psoriatic arthritis patient gets, but they can develop deformities because of the way the ligaments loosen and as part of the pathophysiology of lupus. So this lovely young man followed all the rules, took his hydroxychloroquine, because as you know, rheumatologists in their weird humor joke at meetings that we should throw hydroxychloroquine in the water because it probably would help everybody to some extent. But despite following all the rules, he still ended up one day waking up in a class 5 lupus nephrotic syndrome flare out of the blue, and said, why did this happen? I listened to everything you said. So it reflects that sort of unpredictability that unfortunately this diagnosis confers for some of our patients. More recently, just showing you the crazy spread of organs that lupus can affect. We saw a young woman who had presented with acute delirium encephalitis picture. And in that time period, she was found to have an active COVID infection. But during this workup, she had all sorts of investigations when they weren't quite sure if her presentation was attributable to COVID versus some other underlying autoimmune condition. And over time, we ended up finding that we thought, okay, this is probably going to be COVID. You probably don't have lupus, which crazily enough, in this instance, that's what she was, and I was hoping for. So she didn't have a long-term diagnosis. But in that time period, over time, her serology still persisted, and she ended up eventually getting a classic lupus rash. And she was really frustrated because she said, I thought you told me this was COVID affecting my brain and I'd get better. It's not lupus. Why are you now changing your mind? And I think it tells you that sometimes the journey people take can evolve and change. And even, we probably lack some more helpful tools to kind of be better at getting a prognosis sooner. So even famous people get lupus. I think people might recognize Selena Gomez, who had a kidney transplant for lupus nephritis. Seal, who there was always a debate, does he have cutaneous discoid lupus versus cutaneous TB? But for the most part, my understanding is this probably was the scarring you see as a reflection of limited discoid lupus on his cheeks. And then last but not least, I don't know if people would recognize this lady. This is Flannery O'Connor. She is an author who died of the complications of lupus in, I believe, the 40s, 50s. I might have my time frame a bit off. She wrote a lot of these kind of goth short stories. And here, she lived on a peacock farm. You're not hallucinating, but she developed avascular necrosis because of all the steroid use and her disease in her shoulders, which is why they were severely damaged. And again, reflecting the long-term damage that even our treatments can cause our patients. So there's a lot of stories, and there's like the 1,000 faces of lupus, and hopefully I just gave you a little snapshot of why and how that is. And I want to start by just doing a little bit of epi about, who's getting lupus these days. Well, I think we know autoimmunity really does focus on women, the childbearing age, and the range is quite broad. We have pediatric onset lupus, so in the teens, all the way up until like mid 40s. But we do see it outside of these extremes of age. So we do have neonatal versions. We do see very rarely elderly onset. It's quite rare, I would say, but it does happen. And then we also can see it in men as well. And sometimes those men actually have much more severe disease. It's just we don't see as it's like a 9-to-1 ratio if you look at some of the epidemiologic studies. So in Canada, lupus is sort of hard to guesstimate. The numbers are about 1 in 1,000, so it's not quite a rare disease, but it's not super common. We do see, for example, in population studies in the different provinces, that it does significantly more affect our BIPOC population. So our people of color, Indigenous population, Asian, South Asian, and Black Canadians. There was a study done some time ago that showed that lupus was 2 times more prevalent in the First Nations females in their 40s in Alberta, as an example. And so I only bring this up now because May is Lupus Awareness Month. You'll probably see stuff maybe indirectly on your social media feeds and so forth. And there's a lot of problems with us with drug access, and a lot of our patients who have more challenges accessing care and accessing drugs because of drug coverage. This is a real problem. So I'm not going to give a immunology lecture, but I think just some general principles I just wanted to show because I think it reflects a little on the new therapeutic targets that we are now seeing coming up and currently available for lupus. And so if you had to kind of simplify what are the main players and why people get lupus, it's a three-pronged problem. So your innate immunity, so like your first line of defense, things like your neutrophils and so forth, they are not working 100% properly. They're dysregulated. But you also have a loss of recognition of yourself. So your adaptive immunity, like when your T and B cells work together to develop protections against viruses and other infections, your body's ability to tolerate yourself and not attack yourself is impaired. And then it's a garbage clearance problem. So we know our body's constantly turning over like, dead cells, cleaning things up, or we call them like apoptotic bodies or apoptotic cells. And sometimes the body doesn't clean these up and then presents it to itself, which leads to the whole concept of autoimmunity. So on top of all that, though, there are these other hits, if you will. We know that lupus is not a one single gene problem disease or a monogenic disease. But there have been many different polymorphisms of different parts of the innate and adaptive immune system, complement pathways that may be abnormal. Some are maybe confer more risk for developing lupus than others. So if you have somebody with arguably the wrong place at the wrong time, genetics, who then sees certain environmental factors, has exposure to certain hormonal factors, this all leads to the perfect storm to eventually develop lupus. And so some of the what we call like risk factors from the environment include infections. Many infections have been implicated. There isn't just one. Things from like Epstein-Barr virus, CMV, more recently COVID as a potential additional trigger. In certain countries, other infections like trypanosomiasis, mycobacteria. But again, these are not like just one thing that triggers the whole thing. They just may be one of several catalytic things. Ultraviolet light's really important. We know UV light breaks things and like your DNA and affects T cell methylation and antigen presentation. And so this is something you might see directly when you see a patient who goes out and then gets a very photosensitive rash. That's a nice, clear example of the triggers of UV light. Medication-induced lupus is often a subtype of lupus. But I'll acknowledge it here that various meds, from old cardiac meds to antibiotics, theoretically may be an important trigger for a subtype of lupus as well. And then something probably we don't really think about, silica dust. So silica dust is the product is sort of endemic in our environment. So it's in lots of stuff like cleaning powders, soil, cement, and cigarette smoke. And so I don't forget, I will say, that smoking is problematic in lupus because it actually impairs the efficacy of our anti-malarial drugs. So it's always another attempt to try to promote smoking cessation by telling our patients that your Plaquenil or hydroxychloroquine is not going to work as well when you're smoking. Doesn't always work, but it's, I think, another additional benefit of smoking cessation. So then there's the whole hormone thing. And I think we all obviously know that it is a very female type disease. And it's probably like estrogens make, yes, more hyper responsive immunologically. Maybe there's some evidence in old studies that somebody who had earlier menarche and maybe had exposure to hormones replacement therapies might have an increased risk of getting lupus. But this isn't 100%, but it's one of the things that's in the old days they used to say. And possibly other dysregulations of other hormones and or too much prolactin have been postulated as being potentially having another role in promoting lupus. A lot of women with lupus also have autoimmune thyroid disease. Are they sort of epiphenomenon around each other? We don't know, but the thyroid is something that it's brought up often and patients ask us that. And then there's the genetics. I kind of mentioned genetics maybe in the different types of complex immune pathways that go on from complements to B and T cells. But it's interesting because if you were to say, if you have monozygotic twins and one has lupus, what's the concordance? So it's not 100%. You'll see here a range of 24 to 58%, and dizygotic twins is quite a bit less. But we do know, like if you do a family study, that autoantibodies do kind of run in families or aggregate. So you may have a woman with lupus and she may have siblings or parents or kids, and they may check various autoantibodies. And there are higher rates of those antibodies in family members that are more direct relations. But that doesn't mean everybody else in the family actually manifests true SLE or lupus. And there's lots of studies looking at genetics and ethnicities and the interaction of like gene signatures to do with interferon as well, because that's very important. So it's all fine and good, but in the end, people get lupus and they have all sorts of these combinations. And I think patients are always trying to find a blame or a cause for something. A newer area of research, which I'm sure we hear about in other areas of medicine, is also the microbiome. It's really complicated to study this, but we do know that the gut is one of the gateways of our immune system from the environment. And so one of the theories is that perhaps in lupus patients, their gut microbiome is more restricted, it's less diverse, and this has an impact on promoting autoreactivity with various mechanisms that I'm not going to get through. So lots of research in this area, but there isn't necessarily anything specifically like interventional yet, like should they go on a yogurt diet or something? I don't know. That has not come up as a recommendation thus far, but it may in time. So if you put it all together, this is sort of the last of my pathophysiology slides. We know that there's all those factors I've mentioned, from environment to infection to your genes. And then you can accumulate these apoptotic bodies, these garbage, which isn't being cleaned up properly. And this picture here really kind of is just meant to show you the way like the antigen presentation cells interact with T cells. And then there's all these pro-inflammatory type of cytokines. So if you can see up, I'm not sure if you can see my wiggling cursor or not, but there are various things like interleukin-6, TNF alpha you might recognize from it being a biologic target for rheumatoid arthritis, and this thing called BAFF. These proteins kind of promote interactions that make the T cells then go hang out with the germinal centers, so things like lymph nodes and places where we make our B cells. And if you remember, B cells make plasma cells make antibodies. And it's this autoantibody development, which is a big player in destroying tissues in people with lupus. So the only other thing I'll say on this slide, which I know is really busy, is that if you see these purpley, pinkish little dots here, that they're supposed to represent interferon alpha. So interferon alpha is a big kind of quarterback between different aspects of the immune system, between the B and the T cell parts. And that is one of the targets of a drug that I'll mention at the end called safnelo or anifrolumab. And so you can see why it makes sense that we might want to target this, because it's really important in promoting all this autoreactivity and autoantibody formation. So these days, I think most of us probably still remember the ACR, American College of Rheumatology classification criteria, which was a way to classify people into saying, are they lupus or not? And classification criteria are great if you want to make sure you're describing a population for a clinical trial so that we're talking about a homogeneous group. But if you take my word for it, just because of time, the list here is not fully covering all possible manifestations of lupus. So it has the classic stuff that we might remember with mnemonics from med school, like, I don't know if you remember Soap Brain MD or whatever you might have used to try to remember the main manifestations of lupus. But the problem with classification criteria is they're not diagnostic and they miss people who maybe don't actually meet 4 out of 11 criteria listed here. So there's been work to try to have more sensitive and specific classification. This was a more recent work between the Europeans and the Americans to come up with better classification criteria, where they basically say if you have an ANA, you have to have an ANA or it's not lupus. And then you have various clinical domains and immunologic domains, and they are weighted by, I guess, they're weighted based on studies of other populations. So, if you reach the number 10 or more, then you are classified as lupus. Do I use this in clinic? No, not at all. But the pieces in it, like, do they have arthritis? Yes, of course. That's part of our history and our physical exam. And then on top of that, the blood work that we do. So in the end, in a clinic, we're diagnosing patients by doing a very thorough history, thorough review of systems, back to basics. And I know sometimes maybe people think rheumatologists only look at joints, but in a vasculitis or a lupus patient, every time I see them, most of the time, I probably am doing, a cardiovascular respiratory exam, looking at their joints if relevant, looking at their skin, sometimes a neural exam, depends, looking at their scalp, all the different pieces. So they do require, I think, more thorough bedside evaluations than, I guess, say a rheumatoid arthritis patient who's in for a follow-up and we're just looking at their joints. So speaking of what could we find and what are we trying to capture when we're evaluating our patients, this is a nice, I think, general schematic showing the different rates of what in a person from start to finish in their lifespan, what they could end up developing with lupus. So this is the percentage or prevalence of manifestations. And if we look at the top, I'm just going to go from the head down. It might surprise you because it says neurologic related complications can be as high as 50%. But remember that includes things that are not necessarily lupus specific. So a lot of times there's higher rates or prevalence of headaches, migraines, for example, in people with lupus. There are the serious things like CNS lupus stuff that I'll briefly talk about in a minute, like seizures, stroke, encephalitis. But you can see under it, one of the biggest things is how the constitutional symptoms and fevers can be quite high at 70%. Cutaneous and other related mucocutaneous complications, like all the different rashes or oral and nasal ulcerations are very common. Serositis, so whether pleural effusion or pericarditis, is not as common, but I think it's a real classic, obvious manifestation of lupus if your patient has it. And there are obviously methods to measure it if you needed to with ECG, chest X-ray, or whatever else might be needed. It might surprise people that it's about a third of patients with lupus who develop any form of kidney lupus or lupus nephritis. So it's not a huge number, but it also, lupus nephritis can be one of the more, can confer a lot of morbidity for patients, particularly if it's not identified in time. And so it's a really important thing to continue screening for. GI complaints. I don't know, I think a lot of us think too much about the GI tract when it comes to lupus, but here, in this study, they said up to 50% of patients. And so what they're probably talking about there is in the early period of lupus, like the first couple years, that's probably the greatest risk of people getting GI stuff. It's still not very high, but people can get unusual things. For example, something called intestinal pseudo-obstruction. So mimics a bowel obstruction, but actually requires high-dose steroids. Or small bowel protein-losing enteropathy, that kind of stuff. Lupus hepatitis, not as common, but possible. The hematologic manifestations are quite varied. They say up to 50% here. Things that we see, I guess from an anemia point of view, we have a lot of young women, and so arguably they may have an anemia more because of iron deficiency of all the possibilities versus active lupus. But lupus patients with active disease can develop hemolytic anemia and therefore have really dangerously low hemoglobins. ITP, immune-mediated thrombocytopenia, super common. Well, common, maybe not super common, pardon me. And probably the most common of all the hematologic complications would be lymphopenia, low white counts. So lymphopenia is quite common in our lupus patients, and a lot of times is a chronic thing that we don't necessarily directly target, but possibly with hydroxychloroquine or steroids, if necessary, you might see improvements in the total lymphocyte count. Sometimes we also see neutropenia. It can be seen in some people with lupus as well. And probably the biggest thing, which I find the trickiest, is you'll see that they say up to 85% of patients will have some manifestation of arthritis or other MSK complaints. And that part's the tricky part, because sometimes is it actually an inflammatory arthritis? As I showed you my young Asian male who had the Jacquard's arthropathy, he truly had, versus things that can be confused for it. So things like central pain sensitization or fibromyalgia, super common. In lupus patients. And there's actually controversy in rheumatology right now. So some rheumatologists have found that they treat their patients for their lupus, like kind of classic manifestations. And yet the patients come in and the rheumatologist is like, hey, your blood work's great. You look good. You don't have a rash. You don't have skin joint stuff. And yet they're like, I am tired and I have brain fog and I hurt everywhere and I can't work. And some people wonder, they call it type 1 and type 2 lupus. So type 1 would be the sort of classic manifestations, and type 2 might be another, possibly a synonym for like whatever you want to say, fibromyalgia, chronic fatigue, all of the things that sound the same. Or is it actually that there is a biochemical switch that happens? So that this is the subject of a lot of research in lupus right now. And not everybody agrees on it, but I just want to acknowledge it's probably our biggest complaint is brain fog and fatigue, even in patients who we think are actually in a low disease state. Last but not least, Raynaud's. I don't know if it surprises people that here they're saying only about 20% of patients develop Raynaud's or have it. And I would say that in all our connective tissue diseases, the most Raynaud's is virtually in close to 100% of people with scleroderma. So of all the rheumatologic diseases where you expect Raynaud's, it would be scleroderma. And then you might see it in some with dermatomyositis and some with lupus, but it's not nearly as high, just as an interesting point. So from a clinical point of view, I wanted to sort of talk about, I guess if you're seeing a patient in a primary care clinic, and you're suspicious for lupus, I think there's some baseline stuff that you can do. At a minimum, I would say starting with an ANA, an anti-nuclear antibody. If you're in a rheumatology clinic, like you guys, someone's referred us a patient and they haven't had an ANA, then I would do it. And then I would also add these antibodies. So the ENA panel, extractable nuclear antigens, and I'm going to talk a bit more about it on the next slide. And then the antiphospholipid panel, which is these three things now in Alberta if you order it. So the lupus anticoagulant, the anticardiolipin, and the beta-2 glycoprotein 1. So if you order an antiphospholipid panel, that's what they'll screen for. So at baseline, these are things in a rheumatology clinic we would do. At baseline also, I would do everything listed below. And I think these are also reasonable things, possibly, if you think of, if you're suspicious that your patient in front of you may need a room referral for possible lupus, I would recommend considering doing them as well. So we've listed CRP, C-reactive protein. I acknowledge that CRPs go up for anything wrong with you, right? So if you have a flu or if you have a malignancy or other problems. But if all things are being equal and this is a young person and they're not sick with a cold or whatever, and their CRP is up, it can be a helpful disease activity marker. So that's a useful one in the right context. A CBC and differential to look for cytopenias, renal function, which I think is pretty classic and done anyway. A urinalysis, real easy, quick way to try to at least screen for active urinary sediment, particularly hematuria, proteinuria, and then a spot urine protein creatinine ratio as well. I would also say if you're seeing somebody and you're thinking they may have lupus or another connective tissue disease, if you think of it, it is helpful to do a double-stranded DNA and similarly complement C3, C4. And if if those haven't been done anytime recently and we're seeing them in clinic at baseline, we would definitely do all of that. I put CK, creatine kinase, because some patients with lupus can have a myositis. So I actually do it as a standard, particularly if someone's complaining also of muscle aches or pains or weakness. So I think it's a useful screen. Or maybe they'll have an overlap connective tissue disease of some other sort. So those are at baseline what I would recommend. And then for ongoing disease frequency, the stuff at the bottom I've listed there, I would put on a standing order requisition when we're screening for ongoing lupus disease activity. So I wanted to just show you guys the latest, like our serology panel in Alberta. Well, it's actually, I probably shouldn't say this out loud, but it's driving me crazy because it's changed several times, both with ANCAs and ENAs and how the assays, and they wanted to normalize it across the province, which I think is a good long-term plan, but it's been very confusing. So now, if you order an ENA panel, this is what you get. So they will screen for, it actually does include the double-stranded DNA, I think. So I put it in there, but I always do it separately. But apparently, you'll screen for all of these things here. So I find this confusing, and even we're not sure are they all equally created equal. So I wanted to just outline a couple things. So the double-stranded DNA is a very specific test for lupus. If a patient has a positive double-stranded DNA, there's virtually nothing else this can be but lupus. So that I think is helpful. And also, if we see somebody coming and referred to us and they have a positive double-stranded DNA, they'll probably be triaged as more higher priority just because that is so obviously lupus. Other ENAs that can be specific for lupus is this guy here, anti-Smith. And also sometimes Smith RNP. So lupus patients can have various combinations of ENAs, which may seem kind of weird, but so Smith and RNP can, and either both or one or the other can be seen. And then some patients with lupus can end up with these things, which you probably remember as anti-SSA, which is Rho, or anti-LA, which is SSB. But now the lab has measured two different sizes of SSAs. So I find if you don't really recognize this, you'll be like, well, are they created equal? Is one more important than the other? I would say the bottom line is patients with lupus can have any of these combinations. They often have all three of them, but they may have one or the other. And so for all intents and purposes, people with lupus can have an SSA and a Smith, or an SSA and a SSB and a Smith and an RNP, and it can be all sorts of different combinations. What you will see, though, is that some people with other conditions, Sjogren's syndrome, for example, can also have SSA and SSB positivity. So a little less specific just for lupus, but can be seen. I wanted to identify that even though it's on the panel, on the ENA panel, SCL70 is not something you see in lupus. It's a very specific antibody in some people with scleroderma. And then last but not least, this thing called antichromatin. So antichromatin is sort of replaced antihistone, if you might remember from drug-induced lupus. So some people, when they're screening, and maybe they have a lupus-like syndrome, and it's attributable to the timing of a particular medication. If they're positive for chromatin, it might be related to drug-induced lupus. But to add confusion to the story, some people with SLE, regular lupus, not drug-induced, also are positive for chromatin. So we're seeing, so there's a lot of newer things and combinations. I'm kind of restaging all my patients because I'm not sure what means what and if something's more significant than not. But the gists of it are that double-stranded DNA and Smith are the most specific for lupus. So then you might say, well, what about all that other stuff on the panel? They're not particularly all that helpful, but if you care, like anti-ribosomal P is super rare, but in some people with neuropsychiatric lupus, they're at more risk when they have this antibody. The antiphospholipids we've sort of talked about, the WET panel, but that is a way to screen if the person might be at risk for primary or secondary antiphospholipid syndrome. And what does that mean? That means if they have any history of vascular thrombosis or stroke or heart attack at a young age, clots, or recurrent pregnancy loss. So in the end, I guess, how useful are these things for you and for me? I wanted to give you kind of an it depends slide. So when you look at this, there are lupus patients who we follow over time, and clinically they're quiet. They don't have any complaints. They examine normally, but their complements remain low, even though they've been on treatment and they're good, and their double-stranded DNA is always high. So some patients over time we recognize that are like this, and we call them clinically quiet, serologically active lupus. I mean, that's just a name somebody in Toronto came up with for a research project, but it's useful because there is a subgroup of patients who are like this. And so probably over time, we're less worried about that blood work that it's going to suggest they're going to flare. There are other patients, though, that the complements are normal, their double-stranded DNA is normal, then the complements drop and the double-stranded DNA goes up. And in those cases, that blood work is a helpful tool for us to predict a flare. But there are also people with lupus whose ENA panel is totally normal. They don't have double-stranded DNA or any of the things I showed you, but they all have to have a positive ANA. And they have other like clinical criteria that meet the diagnosis for lupus. And so some of those do exist. And I just wanted to acknowledge that as well. The last thing about the ENAs that I think hopefully is useful to you is that other than double-stranded DNA, which can change and be a useful tool for disease activity, all of the other stuff I showed you on this previous slide here, they are either positive or negative, and they're not going to change in 1 year, 5 years, 10 years. So kind of once they present with their symptoms and they're diagnosed, we don't keep doing the ENA panel over time. It's more of a prognostic tool. So I was trying to figure out what to say about when I think you should refer. I've sort of tried to add that into some of the, like when you're doing blood work and it comes back positive, or if they have certain manifestations. So I did ask ChatGPT. I'm following my kid's suit for studying at school, and it came up with a pretty classic checklist here, which I think is obvious. And I think if anybody in their primary care clinic saw this, that would be, I think any of you would refer these patients. So the stuff that meets the criteria for lupus, right? Like they have a positive antibody or antibodies, they have classic joint pain or rash or evidence of hematuria or clear-cut abnormalities in their CBC, and so forth. And I think that's obvious and fine. When they have these symptoms, if they're positive for ANA, you may then go ahead and do some more specific autoantibodies and then refer our way. If they have autoimmune features, but they don't have a positive ANA, I would still recommend referring them to rheumatology because they may have other subtype of connective tissue disease. The problem that I would imagine happens in clinic is that a lot of times early presentations of lupus can be super nonspecific. And so sometimes, we may send a patient back after being referred for a positive ANA and nonspecific joint pain and say, yeah, no, it's fibromyalgia. And sometimes we're wrong. And I'm super sorry, by the way, if that's true. If they had any positive other antibodies or a complement, we would probably say, yeah, this is probably early lupus. And I'd probably put them on hydroxychloroquine. But sometimes those presentations are tricky and nonspecific. We also know positive ANAs can be associated with other conditions as well, or transiently induced by a virus or whatever. I think we've already acknowledged the existence of like other causes of pain, whether it's like a tendinopathy, which isn't, lupus doesn't do enthesopathy. That's more spondyloarthritis, or secondary like central pain sensitization or fibromyalgia. So I just wanted to acknowledge beyond some of the blood tests I've mentioned that might help your pretest probability of lupus. I've kind of listed them all, but the one at the bottom, abnormal nail fold changes. I think clinically more and more now, there's like one of my colleagues, Dr. Mo Osman, has a nail fold video capillaroscopy group, research study. And in many connective tissue diseases, like especially scleroderma, dermatomyositis, and to some extent lupus, the nails are different. And so here's a picture of it's a little dark, I apologize, but if you notice like your patient's got these complaints and they have some redness at the nail beds, if you have access to a capillaroscope, great. Many of us don't. Some actually have fancy stuff on their phones, but even like sometimes I'll take an otoscope or magnify something on my phone. And if you start to notice at the nail beds, the capillaries, if you kind of follow this alphabet here, you might believe me like on F or H here, they're a little more abnormal. They get more dilated, more tortuous, and sometimes that's a sign of connective tissue disease, including lupus. So that might be a helpful clinical tool And you don't have to be fancy like my lovely friend Mo, but if you're seeing it just doesn't look normal, like normal nail beds in red, that's another thing I think that you can utilize to, I guess, institute a referral. So I guess in the end, this reminds me a bit about my kids started watching House recently, and it's quite dated now. But the funny thing is, all the time on House, they would talk about is it lupus or it's not lupus. So um, everything here requires attribution because there's a lot of mimics that are not lupus, and also lupus patients get other stuff too, right? So so infections, neoplasms, maybe sometimes in the worst case scenarios, other rheumatologic stuff. Um, and then also trying to figure out, is someone flaring or is this something else? I think attribution is just a real key piece here. So in the end, when we're doing the last couple minutes, I'm going to talk about treatment and then we'll open for questions. Obviously, the main goal is the sooner we can put out the fire of inflammation and achieve low disease state or ideally remission, then the more likely we're going to avoid the permanent damage stuff. The best example would be somebody with active lupus nephritis, unfortunately going on to kidney failure and requiring transplant or dialysis. We want to avoid getting to that damage. We want to avoid also the worsening comorbidities, and then, of course, the side effects of treatment. So a lot of the supportive stuff probably seems obvious, but I think it's as equally important as our pharmaceuticals or direct disease specific things. So, recommending sunblock for our patients, calcium channel blockers, specifically if they have like things like Raynaud's and they're symptomatic, osteoprotection, and then cardiovascular risk reduction at a young age. These patients have a much higher risk at a young age of cardiovascular disease. So actually actively treating them as high risk and having targets for dyslipidemia that match like high risk patients is officially supposed to happen. It's tricky when you have a young person with bad LDLs, for example, and they're on so many drugs, though, to add this drug onto everything else. I acknowledge that. But the cardiovascular risk reduction is important, hypertension treatment. We talked a bit about smoking already for the anti-malarial impact. And then obviously physical activity and exercise. And then also age and gender appropriate malignancy screening. So there are higher rates of things like lung cancer, thyroid cancer, cervical cancer in lupus patients. And so we do recommend, the Canadian recommendations that we were part of actually recommended more like annual PAPs, different than I think the most recent general for Canadian women recommendations because of this increased risk. We're going to revisit that with our upcoming guidelines though. And so I just wanted to mention that in lupus, in the first couple of years, unfortunately, the things that lead to death include bad infections or CNS lupus, which is rare, or renal lupus. But then after that, it's actually cardiovascular disease that is the greatest cause of mortality. So it just, again, speaks to this risk reduction. And then I see a lot of young women, therefore I have inadvertently developed experience in pregnancy and lupus. And one of the key pieces for your young women patients is obviously to avoid teratogenic medications, but it is to try to have them in a prolonged period where their disease activity is low or ideally remitted before they try to conceive. It makes sense statistically, and the studies show the same. A bad prognosis would be somebody who's got active lupus nephritis. They have bad pregnancies and they don't do well, and the babies don't do as well. So we do recommend continuing pregnancy safe meds. We do recommend continuing anti-malarial drugs in pregnancy and breastfeeding. If they're on a pregnancy safe medication like azathioprine, then we would recommend continuing that. But we do know things like mycophenolate is very teratogenic and it should be off for at least 3 months. So that is a super important period of time where we often refer them to the obstetrical medicine team to help us co-manage them, as well as sometimes maternal fetal medicine. Okay, I'm almost there, I swear. So the thing about treating lupus, in generalities, I guess, it's all about assessing the total burden of disease and then targeting your treatment to what's the most organ threatened or organs that are threatened. And there is a lot of overlap in what immunosuppressant works. What I would say is that unless contraindicated, which is rare, antimalarials goes for all lupus patients, nephritis or not nephritis, even other types as well, like if they just have skin lupus. And so hydroxychloroquine is really our anchor drug, and it does a lot of interesting things in the immune system. Then on top of that, if they have obviously active disease, then some formulation of corticosteroid, whether it's topical or systemic. We're now moving towards narrowing the total life exposure to steroid because long-term steroids do a lot of bad things. So we would rather have a shorter course of steroid and overlap it sooner with these other drugs that I've listed. So things like methotrexate or azathioprine or mycophenolate, and then some of these newer biologics that I'll briefly mention. And so, I think it's beyond the scope because that's our job as a rheumatologist to help guide what we're going to do. But just to recognize that the choice really matters depending on how they do and also the totality of their disease. The only thing I'll say about steroids too is that we often see patients who can't get off steroids. And yet it's really important to try, and we're trying more than we ever used to, say, in my 21 years of practice. So there's been lupus cohorts where they said even dropping 1 milligram per day or more in mean prednisone actually reduces the risk for future organ damage by like 3%. And so you might think, well, what does that mean? And that could be things like these people are going to get less risk for avascular necrosis, like my, excuse me, sorry. I just had to hang up my phone. Like that lady, that author that that I showed you at the beginning, or cataract formation, or just general osteoporosis, or even cardiovascular risk goes up with steroids. So there's a lot of good reasons to try to truly work, and that's what we try to do to get them off steroids. So here's just some examples of the various manifestations real briefly. I mean, the totality of like things where we might use things like methotrexate and antimalarials and now new drugs in the skin world is amazing. Like there's a lot of really good drugs. So this is a photo of a patient with more discoid lupus, but it is early. So this is the kind of time where if you cool it down fast enough, they're not going to develop the disfiguring lesions that you see on this picture here. But, you can have people who are quite devastated by hair loss when they lose their hair follicles because of the skin inflammation. Or this woman who has significant scarring on her hands from her lupus. Or these people, this is more subacute cutaneous lupus where it can mimic other things like psoriasis on the left, or kind of look more viral or like erythema multiforme on the right. And here's somebody with fairly it sounds bad to use like food terms like juicy, but it's pretty inflamed subacute cutaneous juicy lesions here that you're seeing. Now, some of these, if you treat them, will heal without scarring, if appropriate. And this would be like a super classic malar rash. You can see where very fixed, thick, it even has scale on it, and it's in a photo-distributed area. And here's very bad active subacute cutaneous lupus. So if you're seeing somebody who has a good burden of skin disease, it sort of tells us certain drugs are more useful. If they have arthritis, like this person, sort of like my young man that I told you about at the beginning, certain drugs like methotrexate are still used in lupus as well. And I wanted to identify something that you might see in your practice if you have any lupus nephritis patients. So we're changing, the American College of Rheumatology just came out with recommendations, and we're going to adapt these to Canada in the next year. And so you might remember if you had a patient with class 3 or 4 lupus nephritis on a biopsy, that usually the nephrologists would say high dose steroid taper, and then it used to be my cyclophosphamide, but now most of the time it's mycophenolate. And they'll do that, and then they'll transition them after 6 months to lower dose mycophenolate or azathioprine. Now the recommendation is changing, and we'll see this in Canada too, where in addition to mycophenolate as their first choice, they're going to add a second agent right from the outset. So a lot of times now it's tacrolimus, and then now in actually Alberta, it is approved for this indication, belimumab or Benlysta. And so the reason for this is that the outcomes are so much better. If imagine you have a 30-year-old and you don't want her to have proteinuria into her 40s, 50s, and then worsening renal insufficiency over time. And so this is a big paradigm shift that is happening, particularly those who see more lupus nephritis. Me and Dr. Ainsley Aberhart, formerly Hildebrand, are starting a combined lupus and lupus nephritis clinic. Literally, we did one like a couple of weeks ago. And so this will be something where we're going to try to have more combined care. But the same also goes if they have class 5 nephritis, which is where they're really nephrotic, high degrees of proteinuria, and adding like the tacrolimus, or CNI means calcineurin inhibitor, from the outset is going to be a move that's going to hopefully improve the outcomes of our patients. This is kind of early days, but I think it's an important new thing that I hope will actually improve the lives of our patients more. So when you have other manifestations, though, like the big bad things like CNS lupus, where they have stroke-like syndrome or vasculitis or mononeuritis multiplex, which would be like a vasculitis in a nerve, we hit them hard with high-dose steroids, and then the big guns like mycophenolate or cyclophosphamide or rituximab. Same thing with lungs. I'm going to get to the last part because I know I want to leave time for questions. So the last thing I just want to talk about is the biologics in lupus. This is like my last 2 minutes. Um, this is a pathway that is being totally used up right now in targets for lupus. And so what this is the pathway where B cells become plasma cells. And if you remember, plasma cells make the antibodies. So if you can block this pathway at various stages, you're going to make less autoantibodies and cause less damage. So rituximab kind of hits you right in the middle here. It's an anti-CD20. And then this Benlysta guy that I told you we're now starting to use in lupus and lupus nephritis, it blocks these proteins that promote the development of plasma cells. And then anifrolumab blocks something called interferon, type 1 interferons, which kind of co-mediate the whole thing like I showed you. And so rituximab is actually off-label for lupus, but I'm sure you've seen patients get it in hospital or out. It actually can help for various things in lupus, but it's not actually officially approved in Canada for lupus. But hematologists will use it for cytopenias. Sometimes we'll add it for bad nephritis as well, if we can get coverage for it. So the new two drugs in the lupus world, the first is Benlysta, which I've mentioned for lupus nephritis. And this is something that works really well. It's a sub-Q shot weekly. The patient can take it home. It works great when someone has like classic lupus with joints and skin and maybe other involvement. The problem is in Canada, and particularly Alberta, you can't get it for general lupus other than if you have very good insurance. But if you have lupus nephritis, sometimes you can now get it. So even if you have non-group Blue Cross, so that's good. It's quite safe, but it takes like 6+ months to work. So we add it on to their existing antimalarial or whatever drugs they may have. And then Safnell or anifrolumab. I don't know if anybody here has had a patient on it. This got approved last April on non-group Blue Cross. So that's actually amazing. It's a once-a-month IV and it blocks the type 1 pathway, like those little purple dots I showed you earlier. And it actually is very good for skin lupus. So we're trying to get them to let dermatologists use it for cutaneous lupus. But it works very, very fast. And it also works for other general lupus. So patients would go to an outpatient IV center and the infusion happens and then they go. The one risk is increased risk of shingles with this particular drug. And so the drug company actually will pay for the shingles vaccine to get 1 dose of Shingrix before they get their first infusion. And so we facilitate that for our patients. Doesn't matter, they're all younger, obviously, most of the time. And so last but not least, I just want to acknowledge that cellular therapy for lupus and other rheumatologic stuff like scleroderma and dermatomyositis is coming. And this is potentially going to revolutionize our algorithm. So if you've seen CAR T therapy for people with hematologic oncologic indications, there are studies, and we're going to aim to do one in the next year, where in a nutshell, they basically take your patient's T cells and they isolate them, they modify them, so they express this thing called a chimeric antigen receptor. They expand it, they put it back in the patient, and that means that those genetic CAR T cells will then go and hit all the patient's B cells and deplete them. And the studies thus far have shown like sustained remissions on many patients. They may be able to get off their drug. So maybe sounds too good to be true. We'll see. But I was going to say stay tuned because I think the next 5 years, the revolution in lupus is coming and we're also doing trials and other stuff. So I will stop there. I appreciate your time and patience. I know I had more to get through than I realized, but I'm happy to answer any questions.
Thank you so much, Dr. Keeling. And we do have some questions in the Q&A. So for the first question, one of the participants asked, does having had children slash been pregnant or not have any relevance to the risk factors in women for lupus?
Super good question. I would say not really, not that's really been vetted out. Yeah, either way. So whether you've had some, none, a lot, or a little, or even by relation, like OCPs, having them or not, there's never been a clear-cut risk either direction.
Mm-hmm. And then the next question that we have is regarding pericarditis, does a previous pericarditis apply for risk factors, or does it have to be in a current flare or part of the presentation? Again, thinking about diagnosis.
I would say, like, if someone's coming to you now and there's a suspicion for lupus, and maybe they did, if I'm understanding the question correctly, and they've had previous, like, idiopathic pericarditis, not linked to anything else, it easily, hindsight, could have been, and they get diagnosed with lupus, then it probably was early lupus, I would say.
Hmm. Hmm. And then the next question that we have is, what is the mechanism of action of antimalarials for SLE?
Oh, I love this question. There's a number of different ones. One of them is that they think it it takes, like, when the remember the garbage part where, like, the body, like, like the antigen presenting cells takes in, like, an apoptotic body or an antigen, and it takes it into its, like, lysosome. The antimalarial makes the pH of the lysosome higher, so it's more basic. So then the antigen presenting cell can't break it down and present it to a T cell to then trigger immunity. So it stops antigen presentation. It also blocks, like, these things called toll-like receptors 7 and 9. And then it does some other weird stuff that I forget. I'm sorry. So it's interesting because it probably does a number of things, which is also why it takes several months to do its business. Yeah.
Mhm. Fair enough. And then I think we have time for one more question. Is there any time when we should consider taking a patient off hydroxychloroquine? Was one of the questions.
Really good question. I mean, and I think it's a bit controversial. So I would say at any point, like the obvious stuff. So if we have these patients screened by ophthalmology, and they're getting more fancy with their screening tools that are more sensitive to early change. So if there's any suggestion of retinopathy or high risk, then I would usually stop the antimalarial. If I would say, like, and often over time we dose reduce it. Someone who's been on it for 20 years and they're doing really well, I will try to reduce the dose. And a lot of us do the same. So maybe instead of 300 or 400 milligrams a day, they go to 200, then 200 like 3 days a week. There's the rare time though when we do that. Like, that's happened to me recently. And I had a 79-year-old lady who had had bad cutaneous lupus, and she was on 3 days a week Plaquenil. Long story short, we're like, yeah, you haven't had a flare in 10 years. I think we're good. Let's just stop. And she actually did flare. So it reminded me that it took a couple months, which fit the pharmacology. But in somebody who's been in a deep remission for a long time, that would be reasonable to try to see if you can gently wean it off. The other thing is there's rare weird stuff like cardiomyopathies and muscle stuff that if there's any inkling of that being linked, then I would stop it as well.
Okay, okay. And I think we have time to squeeze in one last question. Um, this is again for monitoring. Should we generally check both C3 and C4 when ordering complements? Was the question there.
Yeah, that's a great question. Yeah, those are the good two screening, like, ones. So just C3, C4. There are other parts of the pathway that you sometimes see in immunology, like C1, C1Q, CH50 used to be something that they would screen. We don't do those anymore. So yes, just C3, C4.
Okay, awesome. Thank you all so much for your time and attention during this webinar. I would like to direct you to the QR code on the screen. We really appreciate your feedback. So if you could please take a few minutes to scan the QR code and complete the evaluation form, or you can look at the link that's on the slide as well, to click that and give us some feedback on the sessions. We do take that into consideration and use it to improve our offerings and to add more and answer different questions. So please take the time to give us some good feedback so we can continue offering you excellent content. Dr. Keeling, thank you so much for taking the time this afternoon to tell us about all things lupus. I know I learned a lot. We sincerely appreciate you sharing this information with us.
No, thanks for everybody's time as well. I know everybody's busy.
Awesome. Thank you all so much.